Welcome and good evening to all of you. So we welcome you to this third episode of the Webflix series, The Third Empire. And of course, today it is on epilepsy and acute neurological disorders. And who better umpire can we have than the boss, Dr. Vrajesh Udani, sir? So of course, till he comes and we start our series for today, since we all know that CIP elections are on and it's just about next 48 hours till the poll closes. So a request to all of you who've still not voted to please log in into your personal IDs that have come to you, and whosoever you wish to vote for, but please exercise your votes so that the right person comes elected. Sir is also joined. Good evening, sir.
Hi. I just
Udani, sir,
renamed
good evening,
myself.
sir.
Good evening, everybody.
Sir Chokhani, sir.
Hi, Rajesh. How are you?
Hello, sir. Good evening.
Good
Yeah.
evening. Good evening.
So good evening, everyone. And as Nehal said, this is another of the rounds of our Webflix series. And we've designed it a little differently. So there is no PPT and there is no set topic to be completed in the given time. And we would encourage all the audience questions that everyone has a doubt in their mind. So we've just defined the area that is primarily meant for discussion. Dr. Aditi Shah is the moderator for today. She'll just kickstart the process with a few questions, and then whoever wants to ask anything can please put it in the chat box, and those questions will be given a preference and will be discussed with Udani sir. I think we'll start the process. Aditi.
Yes, sir. Thank you very much, Udani sir, for giving us your time. And without any further ado, I am going to start with the first question, which is related to the most common neurological condition which we see in our practice, sir, and that is febrile convulsion. It so happens that after listening to your lectures, we have managed to start treating a simple febrile seizure the right way. But we do see children with some things when they come, even with a simple febrile seizure, something like a family history or a neurocutaneous marker, or sometimes they have a second seizure on the same day or two seizures every day with fever, and so on and so forth. So my question to you is, when are those cases of even if a simple febrile seizure that we as pediatricians need to be a little bit more alert when treating?
Yeah, hi. At the outset, let me thank you all for asking me to come and discuss this. This is a very nice kind of platform to have these informal discussions, and I think I would encourage anybody to interrupt me or ask me the questions, even if if you think I'm not, if you're not satisfied with the answer. Anyway, the thing is this: febrile seizures, are just, if your definition is seizures with fever. Simple febrile and complex febrile are the two types. And when you basically are interested is there going to be epilepsy in the future? That is the main question, because recurrences, everybody knows, occurs in about a third will have a second seizure, and maybe a third of that, so 10% will have a third seizure. But everybody's interested if will this go on to have a febrile seizure. And what are the things which actually make the risk slightly higher? The complexity of the seizure. So everybody knows atypical febrile seizures, but now the term uses complex febrile seizures. And complex are basically single in a particular day, brief, and basically or generalized. If you have one complex feature, the risk will actually become almost 4 to 5 times more that you might be actually dealing with epilepsy coming in the future. So the risk is there at about, say, 10%. Normal risk is about 1 to 2% in simple febrile. The risk goes to about 9 to 10%. If you have two complex features, so you have, say, multiple seizures and they are prolonged, then the risk doubles from the singles to 20%. And if you have all three, that becomes 50%. So those are important questions you must ask when you're dealing with a febrile seizure. Second thing which is important is the family history. So family history raises the of epilepsy, not family history of febrile seizures, family history of epilepsy raises the risk factor a little bit. Not too much, but a little bit. Third thing is there something in the past, a neonatal story, some encephalopathy. For example, hypoglycemia, as you all know, is a very common cause of afebrile seizures, but they can present as febrile seizures initially, very often complex febrile seizures. And maybe something in the past history like, some insult or whatever it is, developmental delays, all those things will tell you that this possibly is epilepsy. Now, does this mean that you should treat all these patients? No. I mean, there is most of your complex febrile seizures, except for the ones which are, very many complex features, most of them are going to be 5-10% risk, 10% risk at the most. And you don't want to treat that unless the risk goes above 50%. Frankly, it's not necessary that you must treat, but you must explain to the parents. And then sometimes the parents insist on treatment. That's fine. The last thing is febrile status epilepticus. That the only thing is there's a higher risk of febrile status epilepticus occurring again. So you may want to consider that as a separate entity because those patients might have problems in the future.
Okay, sir. And if at all we would want to start with short-term prophylaxis, clobazam would be our drug of choice. But so for long-term anti-epileptic drugs nowadays, levetiracetam seems to be the favorite of most of the pediatricians. What is your advice? What should we be preferring, and when?
Well, in the past, basically, we were using valproate, and nowadays people are using levetiracetam. I'm not aware of any studies in febrile seizures for levetiracetam, but it seems to work as well. The only drugs which I would avoid in any case of febrile seizures is basically sodium channel blockers. Because remember, I mean, this is an important point. Complicated febrile seizures can be, or complex febrile seizures could be the initial manifestation of Dravet syndrome or one of the genetic disorders. And these kind of seizures, I mean, if you treat them with carbamazepine or anything of that sort, you can get serious consequences. So you may go into status and you may have many more seizures that you would actually have and actually cause a worsening. So in those situations, with the very early onset seizures, say within the first year, maybe 6 months, earlier than the 6 months, patients with hemiclonic seizures already have febrile status. Once those kind of patients, if you're going to treat, and you may treat without question, valproate, clobazam, maybe topiramate, but all those things are if you're really suspected them very strongly, and if you in fact actually prove it. But otherwise, generally, valproate would be my first choice, but people can use levetiracetam as well, no problem.
So, and there's a question. So, if we find that the risk of epilepsy is close to 50%, should we start treating upfront? Should we do an EEG, or should we wait for the next seizure?
Well, it all depends case by case. If you have a neonatal story, I would image them. If I see image abnormalities, I would definitely do an EEG. If I see EEG abnormalities, I would go ahead with treatment. If I have a very strong feeling that this is probably Dravet syndrome, coming initially as a complex febrile seizure, which is the way it comes usually, or maybe sometimes even a simple febrile seizure, but early in the course of so 6 months, 8 months, that kind of picture. I don't do an EEG because EEGs are not very helpful, but I might, in fact, if there's nothing else, I would in fact even think of getting genetics done if I'm strongly suspecting it. But you see, once you go into these rarer things, it's better to, take somebody's opinion also. There are many reason being that it's all expensive investigation. So I think simple message I want to give is even if you have a complex febrile seizure, even if you have a family history, try and treat initially with intermittent clobazam and your usual measures. And it's only when there's very strong suspicion of something else going on that you may actually do a further investigation, or you may take a second opinion and find out whether you really need to do anything. But first seizure, I would definitely just do a simple thing. Even EEGs are not helpful in complex febrile seizures in the majority of cases.
And if we get a child with a simple febrile seizure, but this child over the next 2 to 3 months with every fever episode keeps on getting a simple febrile seizure again and again. So the question is the number of febrile seizures, even though simple, will help us decide if we need to start long-term aid?
No. The only thing which decides in that situation where you're sure it's simple febrile seizures, where you're sure it's, everything else is fine, the child is developing fine, it never exceeds few minutes. I would just give maximum intermittent clobazam, keep reassuring. And the only time you would maybe consider is if they are very, very anxious or they're very far away from, medical help and stuff like that, which is very unusual in Mumbai. So I don't think that's a problem. But generally, of course, midazolam spray, etc., you must tell them how to use, demonstrate on a doll if possible, because many people give it wrong way. You never give midazolam spray lying down. You always raise the head 45 degrees or so, because the nozzle has to be upwards. And that has to be told to them, because many people are, even now, when they do that, then they give all wrong doses. You cannot just give two sprays. For a big boy, if you're using say a 10 kilo child, if you're using 0.5, minimum 4 sprays. And it has to come as a spray. So I think these are important, minor points which are usually forgotten, because everybody should know how to give the spray, but they're not given properly. And that's why it doesn't work. There's a question.
Mohite sir is asking, what is the risk of MTS on recurrent febrile seizure?
That's $1 million question. The risk of MTS in simple febrile seizure and even complex febrile seizures is low. The risk of febrile seizures, febrile status epilepticus, the risk is a bit higher. And there's been a big, large study going on for the last 10 years. Because what happens with febrile seizures, you are worried that you might have a long seizure, febrile status, and you might actually damage a part of the brain called the hippocampus, and then hippocampus becomes sclerosed or becomes gliotic over the next several years, and then comes with temporal lobe epilepsy in the future. And this was seen earlier with surgery. When you're doing surgery on temporal lobe epilepsy, the history of febrile status was quite common. That's why the study was started to see. It's called the FebStat study. And it's going on ongoing, because they've recruited patients with febrile status, done their acute MRIs, and then followed them up. And what the preliminary results are, that some people do have swelling, which goes on to have hippocampal sclerosis, but many do not. And some of them, in fact, have sclerosis before the febrile seizure. So there is, it's not one thing. So it's difficult to answer that question now, and maybe the answer will come in the next 10 years when the study will be finished.
So coming back to simple febrile seizure, so if the parents are well educated and they understand how to give midazolam spray properly, is it now okay to not prescribe clobazam at all? Has it been given away, short-term AED?
Well, that is a question of, it's generally, it depends on the psyche of your parents. And my feeling is that over the years, we tried this American and English way of not giving anything. And it just doesn't, they just feel very anxious, and they're watching them all the time. So it is a question of your patients. You have to look at the parents' mindset. Are they cool people? Are they okay with not treating? Are they just, there's no problem? Are they anxious and crazy and all that kind of thing? It's better to give clobazam. I don't think clobazam has any major side effects in the short term. They become a little irritable, they become a little sleepy, but those are all minor things compared to what suppose they see a seizure, they all rush to the hospital, and then somebody or other starts them on long-term treatment. So I think that's a danger.
So there's a question, is there such an entity known as febrile seizures without fever?
Well, actually speaking, No, I don't think so. Maybe there are some people who have said this, but for example, you can get afebrile seizures during illness. Now, and you may get seizures with very low grade fever. And those are the ones who are prone to have recurrent febrile seizures. So afebrile seizures, most important thing is most parents in India often don't take the temperature. Your hand is your thermometer. And the hand thermometer, how inaccurate it is. So you have to have, first of all, you got to tell the parents that even if you get a seizure, please measure the temperature, just after the seizure. And you might very often find that there is. Also, second thing is, they say fever, nahi tha, but the temperature rises afterwards. And therefore, we now use this thing that the 24 hours straddling the febrile seizure. If you had fever, you would still consider a febrile seizure. In low-grade temperatures coming with seizures, it's 99.8, 99.5. You might get it. Yeah, so. Hello?
Everyone, please mute yourself. Thank you. So the question is, clobazam should be given in 2 divided doses. Is that the preferred route? Is that the preferred number of times to give? And one more thing, generally we say that the chance of getting a febrile seizure is maximum in the first 2 days of high fever. So should we stop it on the second day if the fever continues on the third, fourth, fifth day? Should we continue it or stop it?
These are, things which are, I usually say 2 to 3 days. Because the usual febrile seizure is 1 day. Maximum risk is the first day. But 2 to 3 days, twice a day is fine. 1 day, once a day also is fine. But remember, clobazam has a half-life of about, 16 to 18 hours. So the level will start coming down around that time. So if you give it 12 hourly, you're maintaining a steady level. That's the only thing.
Okay. And so sometimes post a febrile seizure, the TODS continues for a very long time, half an hour or more. When should we decide if this is a non-convulsive status? Suppose there are resource poor setting, we don't have a continuous EEG monitoring.
Are you talking about febrile seizures?
Post febrile seizure, TODS paralysis. Even a seizure.
It's extremely unusual. That means you're talking straight away that this is basically a complex febrile seizure. I don't, it's so off febrile status. So you're talking about one of those complex type of things. Usually, hemiclonic seizures for short seizures, even if they are focal, I really can't remember a single patient where I've seen a post, unless he's got a lesion or some gliosis or he's got something from the past. And that is, had a febrile status and then he's had a hemiplegia. So, example, HHE syndrome, which is I don't know if you people know this, is hemiconvulsion, hemiplegia, epilepsy syndrome. So, you get a long convulsion. It's called acute convulsive hemiplegia. So it looks like a stroke because you have fever, you have seizures, which are usually long, and then you are left with a hemiplegia. And that hemiplegia may look like a postictal TODS, but may actually go on for a long time. It may remain for a long time. We do an MRI at that time, we find that the seizures themselves have caused damage in the brain. And then that patient often develops epilepsy in the future. So that situation happens in patients who have long seizures. And this used to be very common, not only in India, but all over the world, when there was no treatment at home. This midazolam and buccal midazolam, nasal midazolam, rectal diazepam gel, which is used in the US, those things have made long seizures very unusual. Of course, in the West, you also have EMSs, emergency medical services, etc. But if you have a long seizure, I'm talking about febrile status going on for 2 hours, 3 hours, 4 hours, of course, you will get damage. And that's what causes a hemiplegia often. Post-ictal TODS, happens very commonly when you have a focal seizure with a lesion, and that, even without lesions, it goes away. But generally, I have not seen a regular simple febrile seizure or a even a complex febrile seizure coming with thoughts. So I would
Okay.
definitely investigate that.
So there's a question, has the age for defining a simple febrile seizure gone down to 3 months?
Well, simple febrile seizure, I do not think. Febrile seizure, yes, you can get at 3 months. And whenever you have a febrile seizure below 6 months, you always think of the bad ones, like Dravet syndrome. If you have, or something else, but like a meningitis coming up or something of that sort. But if you take at the febrile seizures consensus, which was published by the AOCN a few years ago, I think we had a lot of discussions, debate, and all that. We kept it at 6 months to 6 years. Anything after 6 years, uh, if it's persisting beyond 6 years or it comes below 6 months, you would classify them as febrile seizure plus and stuff like that, or something is happening besides the febrile seizure, especially those who had seizures going on for beyond the age of 6 years. Remember, about 5% of febrile seizures may continue to 10 years of age, not only 6. And it's not, it's not like a common thing, but it can happen. And that you call febrile seizure plus, which is part of the JEF spectrum, generalized genetic epilepsy febrile seizure plus. So that group is, a little different, and their family history positive and stuff like that of epilepsy.
So suppose a child who is already on some anticonvulsant drugs, sometimes they come to us in our routine OPD and come with symptoms like this child is sleeping excessively, or sometimes even the child has become very aggressive. Sometimes the child has a rash. So the question is, when should we, what are the red flag symptoms that we as pediatricians should be monitoring for a child who is on anti-epileptic drugs? When should we be doing drug levels? When should we stop the drug and things like that?
So first, before I answer that question, I want to tell you the first thing you said about sleeping. Patients are looking for side effects. Sometimes they come कि ये दवाई चालू है जब से हमको बहुत ज्यादा सो रहा है ये वो. So I always ask. Usually, if it's because of the drug, it usually happens 2 to 3 or 4 hours after the drug is given, and it should happen in the morning and the evening because most drugs are given twice a day. Surprisingly, then they say नहीं रात को तो 12 बजे सोता है, लेकिन दिन में वो सो जाते हैं दोपहर को. The answer is obvious. He's not getting enough sleep in the night. So this is one of the things. Before otherwise, if you have a child who's sleeping a lot more, obviously more, after a couple of hours after the dose, 2-3 hours is usually the peak time, then definitely you should either cut down the dose if it is recently started, that this is a new symptom, definitely you must cut it down. If you want to do a drug level, fine, but there are medications where we don't have drug levels commonly available. For example, clobazam, for example, all those things. You may have the old drugs which were used, phenobarbital and carbamazepine, etc. Yes, but the recent drugs is a little more difficult to get drug levels. You could just cut down the dose. Maybe the best mantra is, if you're starting something new and you want to avoid side effects, just start low and go slow. That's a common thing to everybody uses that same thing. Rashes, I remember, are idiosyncratic. I'm absolutely terrified of rashes coming with sodium channel blockers and some of the others. For example, lamotrigine, of course, is the most famous, especially if there's valproate going on. Carbamazepine, oxcarbazepine is much less. Phenobarb, phenytoin, absolutely right there. So all the sodium channel blockers, some of the other types, the phenobarbital is obviously not a sodium channel blocker, but even, for example, zonisamide. Because remember, these are idiosyncratic. No way of finding out. One of the reasons we always start slow, and we have a patient who has one of these common drugs with a rash, you're worried. You may be less worried if you are, say, on levetiracetam, which rarely gives rise to a rash. You may be very, less worried if it is valproate, rarely gives rise to a rash. But the sodium channel blockers are definitely, because if you don't look, if you don't prescribe it properly, also the rash can be a severe problem. I remember I tell you a story. If you indulge me, I tell you, I had seen a patient on Lamitec who was put on lamotrigine. I said, Lamitec 5 milligrams. That patient went to the chemist. I don't know what happened. I gave him the entire thing. I kept a copy of the prescription. That patient had a, later on went to some hospital, Nanavati Hospital, I believe, where I saw some other patient. And the resident asked me over there, one of your patients came here and saw you had given him 50 milligrams of lamotrigine. So I said, what are you talking about? I've never given anybody 50 milligrams in the beginning. So he had a Stephen Johnson and he died. So I wanted to investigate this. So we investigated and we found that he went to the chemist. The chemist says, ये 5 मिलीग्राम है लेकिन नहीं 5 मिलीग्राम मिलता ही नहीं है 25 में मिलता है 50 में मिलता है 50 दे दिया. Patient actually died of this. After that, I went to the Cipla company. I said, you please give Lamitec Kid. And they changed it to Lamitec Kid and gave 5 milligrams. Because this is what happens, Chemists are doctors according to themselves. And they also, and this is very dangerous. So you have to be very careful. Write legibly, write in capital handwriting, and please keep copies. If these things go bad, nowadays in this litigious atmosphere is getting worse and worse, you'll really get into trouble with Stephen Johnson and rashes and stuff. Anything else? I mean, adverse effects, There's no questions. We want to take them.
Not on this topic, sir. So I think we'll go to the next topic.
Okay, fine.
Go to meningitis. There's already a question. What is the preferred duration of aspirin in TBM with infarcts?
Great question, because there is no real answer. Usually tuberculosis meningitis. First of all, is there clear evidence that aspirin works? The answer is no. There is no clear, there's one study from Lucknow which sort of gave aspirin to adult TBMs, but there was a problem with the study because they were not adequately matched and stuff like that. But the infarct rate was a little lower, but did not change the outcome of TBM. But aspirin is routinely given by most people now, because it stands to reason there is some TBM is a procoagulant state. And just in case you didn't know this, there seems to be procoagulant activity in TBM. Aspirin seems to at least prevent some strokes, if not all. So I think it's definitely worth giving. How long to give is not being studied, but I prefer to give it for the active part of TBM. So when is the active part? The active part of TBM is 3 to 4 months. That's the time when you get complications of TBM. The infarcts come 3-4 months. So giving it for, say, 6 months, but not beyond that. Now, some of these patients develop moya kind of disease, secondary moya, where the vasculature becomes all stenosed and the collaterals and stuff like that. Now, those patients are a different kettle of fish. I give them for a longer time. But generally, as a prophylactic, and I'm not advising you to do MR angiograms in everybody with TBM. But in case patients has strokes and all that, and you have to do an angiogram, please make sure that if there's moya coming up, give aspirin for a much longer time. Otherwise, generally, a few months will be enough.
So coming to a bit of a basic understanding for meningitis. So if a child comes with fever, neck stiffness, we suspect a meningitis and we want to do a lumbar puncture as early as possible to start the antibiotic in case we are suspecting an acute bacterial meningitis. So my question to you is, do you advise doing any kind of imaging like a quick CT every time before doing a CSF or just a fundus and papilledema is good?
I am very clear on this. LP, in a case of suspected meningitis, it has to be suspected, there has to be fever, there has to be, certain criteria to be met before you say, you must do a CSF immediately and you must treat immediately if the CSF is cloudy, etc., etc. It is parenteral antibiotics. Doing imaging is sometimes advised in certain types. And there's a focal deficit, for example, or when there is a papilledema is very unusual in the acute stage. When somebody comes to you with an acute meningitis, even if the pressure is very high. Thirdly, most severe meningitis comes in the first couple of years of life when the risk of herniation is low. So really, generally, it's unusual to do. I mean, there's no reason to do a CT scanning. Of course, if you have significant, I mean, patient is having significant alteration, if there's some suspicion, there's a focal deficit, there's some suspicion. I can't give you a, sometimes you feel there's something more going on. In that situation, get a quick CT, no problem. And look at the basal cisterns. And of course, look for any mass. But generally, the basal cisterns are open and there is no mass. You can do a CSF. But doing it for every patient, my God, CAT scans are dangerous things. They can cause, there's a higher incidence of cancer in the long term. So please avoid CAT scans. Absolute necessary, yes.
What is the role of CSF biofire? Should we send it in all patients?
Well, it all depends. If you see first of all, you have to understand that what you are looking for treatable cases of, if you have acute meningitis syndrome, so you do not have, or a meningoencephalitis, what can you treat? Okay, you can treat the bacteria for sure. You can treat the fungi, which are very rare in the usual case, so unless there's a background of some immunodeficiency or something of that sort, you don't suspect. You can treat things like TB, but that's usually a much more subacute situation, but still that's one of the things. And the last thing you can treat in viruses is herpes. So usually in the young, so when is the things which virus is causing a meningitis syndrome, not an encephalitis syndrome, are much common in the school age group, the older age group. Bacterial meningitis is much more common in the below 2 years, below 1 year age group, infants and stuff. Of course, you can get it any time. Doing a CSF biofires in every patient is obviously an overkill, but if the patient can afford and all this kind of thing, it's worth doing because you're getting first of all, you may avoid giving antibiotics for a longer time. Say something like enterovirus comes positive or something, you can stop the antibiotic, even if you've started it. So those kind of considerations have to be there. What is it very good for? Actually, it's very good for pneumococcus biofires. But the culture in an untreated case is as good or even better. So it's not that, because the main one is Streptococcus pneumoniae. H. influenza, by the way, is not very well picked up by biofires. In fact, many things don't have H. influenza. Of course, now with the HIV vaccine, of course, that has become much less. But generally, culture, in my opinion, if you are suspecting bacterial and cloudy CSF and all that, that would be the time when culture would be better. And if it is treated, maybe you can do latex, though most people have stopped doing it and just do the CSF biofires. But if you are not sure, do the CSF, wait for the cell count. If suppose there is no meningitis only, there's some 5 cells or 2-3 cells or something of that sort, or suppose like 5 or 10 cells. Why do you want to do CSF biofires for you don't think it's a bacterial meningitis? You can wait there. But if there's an encephalitic syndrome, then yes, CSF biofires will be required because you don't know whether it's a herpes or something of that sort, and you want to do the treatment for that.
Right.
I don't know if this is because to be frank, you guys treat more meningitis than I do. And if you have any, points in this which I may have not brought up, you can tell me. Somebody asked a question.
Yes, sir. Is it possible that biofire picks up something that is not relevant?
Not
relevant. As in many times. We get these
Well,
all.
yes. Well, it can confuse you with the viruses because some of the viruses, like DNA viruses, typically, which are typically HHV6, HHV7, maybe CMV. All these are DNA viruses, and the biofire doesn't usually differentiate between dead viruses or just a material which is there for a long time and live ones. Of course, it's very useful for RNA viruses because RNA viruses don't remain in the CSF. But otherwise, like I said, H influenza, you may get a negative one. Cryptococcus antigen, Cryptococcus biovirus, fungal is very often false positive. So that's, I think, some of the ways you avoid those. Japanese bee encephalitis. Japanese encephalitis, the better diagnostic test is a CSF IgM ELISA, which is not done. You cannot do it except in Pune, and that will take some time to get back the result. The Japanese encephalitis PCR is quite much lower than what you would expect, 50%, 60% or something. So it's not like everything is picked up by it. And everything is not excluded by it either.
So the question is, HSV encephalitis needs treatment with acyclovir. Does HSV meningitis also need treatment?
Preferably, yes. I mean, I think so. HSV meningitis is quite common in adults. It's not so common HSV2 meningitis because HSV2 is a sexually transmitted disease, and it can occur in adults. In children, I think anybody who gets, for example, varicella. We give patients with complicated varicella, which we always give acyclovir. So I don't see any reason not to give it in the case of herpes virus, the meningitis. And you never know how the course of the disease is going to go. That's a problem.
So mumps encephalitis, meningoencephalitis, do we give acyclovir?
I'm not aware. I don't know if anybody else is. I'm not aware. Do you give? Anybody who's asked the question, maybe?
Dr. Rohini Kokati.
I'm not sure. Maybe you have some experience or some knowledge about that. I'm not aware of that.
If
Anyway.
anyone has information, you could put it in the chat box. So
Yeah.
Questions. In acute encephalitis, can you share some clinical clues to differentiate viral versus cerebral malaria?
Difficult. You can have, the hematological clues and all that, yes, but you just look at clinical clues. Frankly, viral encephalitis are usually more acute and more dramatic than cerebral malaria is one thing. But that depends on the virus also. So it's not cut and dried. Cerebral malaria, frankly, I haven't seen for many years now. And what my experience has been in the past is it comes a little bit less acutely as compared to encephalitis, but that's really more all I can say. Focal deficits can occur in both. Seizures can occur in both. Alterations. Cerebral malaria rarely comes with significant rises in pressure, but even that can, may not be true really. So I'm sorry, but I cannot tell you more than that. Otherwise, all of these come in the group of acute febrile encephalopathy, and it's very difficult to differentiate only on the basis of clinical clues. So what you need to do is seizures and altered sensorium is an encephalitic syndrome, headache, vomiting, and that thing is a meningitic syndrome. And sometimes you have both. The younger you have, the more chances it will be a meningoencephalitis. And then you have to, do all the routine stuff. You should get your blood tests and all that. Everybody does, especially endemic areas, cerebral malaria. For example, if you have a spleen or something, I suppose you might think of it, but frankly, I don't see so much cerebral malaria really in my practice. Anybody else has an opinion on this? Please tell us.
The presence of neck stiffness, Sambal sir is saying, may go more in favor of a meningitis rather than a cerebral.
But if it's not there, would you not do the investigations? You would, no? Maybe you do a CSF first. The CSF is normal. You would have want to exclude this by doing a smear, no? So I think it's like a okay.
Okay. So coming to the next topics, I think meningitis, you had a very vast discussion. One more question, so last question on meningitis. In neonates with sepsis, CSF study often reveals no pleocytosis. Is that your observation too?
Yes, that means neonatal sepsis and not meningitis.
Okay.
So you have neonatal sepsis, which is actually a syndrome. It's not necessarily caused by an infectious agent. You can get a neonatal sepsis picture, clinical picture, many things. But if you have a CSF which is not showing any pleocytosis, and the problem is this, that in the newborn, the CSF count also, I think it's 30, 40 cells or something. If you have polymorphs, it's a little significant stuff like that. But generally, if you have a normal CSF, you don't worry about it. If you have a low sugar, of course, you must always do a sugar along with that. And remember, do the sugar before you do the CSF, because when you do a CSF and then do the sugar, because of the adrenergic rush which happens because of pain and all that, the sugar might actually go up, and you might get a falsely positive CSF sugar ratio, CSF plasma sugar ratio. So basically, do the sugar always. And if you have low neonates, notoriously common to have low sugars. So
in fact, the question is that how do you interpret the pleocytosis when the sugar is less than 20? I mean, absence of pleocytosis when the sugar is less than 20.
Yeah, that's what I'm saying. The CSF sugar, if it is low, the first thing is, does he have hypoglycemia? Because hypoglycemia can present like a clinical sepsis syndrome. They can become cyanos, they become limp, they can have seizures, they can get all those kind of things. So first of all, you have to check the blood sugar. The blood sugar is normal and the CSF sugar is low, and there is nothing in the CSF otherwise, no RBCs, no. Then you think of things like GLUT1 deficiency syndrome and stuff like that. But usually, before you embark on a expensive investigation spree, it may be better to repeat that. But usually, I think the reason is this low sugar in the blood, so low sugar in the CSF. So primary hypoglycemia in the CSF is typically seen only with it's not only seen, but typically seen with GLUT1 deficiency, where there's a problem of transport of glucose into the CSF. The other thing I must mention, though has not been asked as a question, is when you treat neonatal meningitis, your sugar very often remains low. Your cells don't necessarily go down to complete normal for a long time. Now, whether this is because of, it's obviously the cultures are negative, the baby is doing fine, you give it your antibiotics for 3 weeks, CSF is still showing a little low sugar and little low. But that is, I think, primarily because there's been a bit of a problem in the glucose transport. Now, this glucose transport change occurs, it's not for a very long time. It's transient, so a few weeks or months or whatever, and then becomes okay. So it doesn't look for that, remember that. So that can be one of the reasons for low sugar without the corresponding cells. If you had a meningitis picture before, remember that sometimes can happen, and people have referred patients to me and say, kya karne ka, what do you do? So what you do is, if the culture is negative, the CSF cells have come down significantly, but not to normal. The CSF sugar is low, but it's come up a little bit. You can stop the antibiotics in hospital, wait for 48 hours, 72 hours, and then repeat the CSF and see what happens. Has the cells gone up? Has the culture come back? Something of that sort. Just to confirm that it is not just a little bit of low sugar persisting for a longer time, even though the meningitis has now disappeared. Is that clear? I mean, yeah.
Should we go to the next topic, so of headache?
Whatever you want.
Okay. So headache also is a very common symptom parents come to our clinic with their children. So most of the times it is not very severe, and we have ruled out most of the red flag symptoms associated with headache, and no other acute neurological signs are there. So when do you decide to investigate this child with headache?
So what? Let's say, let's just look at the whole broader picture. 95% of headaches in children are benign. Okay. Many of them are acute headaches because of some fever or that kind of thing, some febrile illness, etc. Very often, then of course, the bad headaches are the ones where you miss a meningitis, or there's some bleeding, or there's some acute problem like that, or there's a chronic problem, subacute chronic problem like a tumor or hydrocephalus or something like that. So what tells you that something is going wrong? What is the age? Very young patients, usually below the age of 5, maybe 6, 5, 6, headache is an uncommon symptom. So a new onset headache, though migraine can occur as early as 3 years. But if your headaches have come up and the baby is actually verbally telling you, take that seriously. Second thing is, if it disturbs you at night, I think that most people know this. Though migraine and other headaches rarely can disturb sleep, especially in chronic migraine, most of the times you will not get up because of the headache unless there's something going on. And the reason is obvious. The pressure may be going up in the night because of the recumbent position, and therefore your drainage, venous drainage is a little less. And therefore, if you have something which is already giving intracranial pressure, it increases in the night. And therefore your headache worsens. Third is, if it's a recent onset of headache and it's worsening progressively. So it started maybe once in a, every second, third day, and then goes on increasing. So anything less than 2-3 months, you're worried. Something going on for a year or two, I'm not. Intermittent versus progressively increasing, I would think it's worrisome. But remember, if the headache is not disturbing activity and just is a constant kind of headache, most of the times those are not serious headaches. So I think the type of pain, severe pain doesn't mean a thing. Vomiting usually doesn't mean a thing because many migrainians vomit at the slightest. Transient visual disturbances, or which are more complete loss of vision, especially in older patients, older children who tell you, I can't see anything for a few minutes, that's serious. That usually is a pressure symptom. So it's called transient visual obscurations. That's something which you must take seriously, because visual auras can also be confused with that of migraine. So generally, if you don't have a typical thing of migraine, the type of auras, then you might think of something like that. And otherwise, of course, focal deficits, seizures, etc. sometimes will obviously tell you there is something more than just a regular thing. I can't think of anything offhand, but anybody else has any, say I missed out, maybe you can, just say it out. Yeah. So those are some of the red flags. Yeah. Sorry.
Acute encephalitis syndrome. How common are the non-infectious causes like autoimmune diseases? And should we always investigate for these?
Depends on, in India, infections are still the rule, but the number of autoimmune is going up steadily. So I have a slide on this when I talk on acute encephalitis, and I updated the slide. And I should show this data from the US, where about 40% of patients have autoimmune encephalitis in the California Encephalitis Project. In India at that time, this was sometime in 2009, 2010, majority were meningitis, meaning infectious. But if you look at data now from India, after the advent of the autoimmune encephalitis boom which is occurring, it's gone up to as much as about 15-20%. 15%, 10, 15%, depending on what you read. So really speaking, it's an important cause. And therefore, if you have an acute encephalitis syndrome, especially if it's not very acute, but it's, subacute, autoimmune encephalitis, especially other things like movement disorders and behavioral changes and psychiatric changes, etc. You must consider that in your differential diagnosis. And obviously, you must rule out infection first. And if everything is ruled out and still kid is encephalopathic and having any of these symptoms, and the MRIs sometimes doesn't help at all, but sometimes does help. So all those things, then you can think of methylprednisolone. I mean, you can think of doing tests for autoimmune encephalitis. And remember, the most important autoimmune encephalitis in children is NMDAR, and the most common demyelination is ADEM. Now, MRI will show pictures of ADEM very easily. In fact, it's one of the criteria for diagnosis. But NMDAR may be completely normal. So you will need to send that. That's the most important and common. So you don't need to send the entire panel, which everybody does all the time because it's expensive. Even if everything is negative, your panel, and everything is still negative, the kid is still call it seronegative autoimmune encephalitis and treat it. And with methylprednisolone, IVIG, whatever. So basically, remember one thing, it's not commoner than we think. And
Okay. And sir, IVIG in encephalitis?
yeah, if it's autoimmune, yes.
Okay.
I mean, in ADM also you give steroids and sometimes you give IVIG, sometimes you do plasma exchange, etc. But basically, any immune therapy, these are the two most important immune conditions in children. One is NMDAR and the other one is ADM, which give rise to. The third important thing is ANEC. And ANEC, as you could know, is acute necrotizing encephalopathy of children, of childhood, and is most common below the age of 6 years. In fact, most common below the age of 2 years. And in these patients, there's a treatment available now, which you must therefore diagnose as soon as possible. And that is, you get these thalamic changes, bilateral thalamic, very often hemorrhagic. There are changes sometimes in the brainstem, sometimes in the cerebellum, sometimes in the white matter, but the most classical is in the thalamus. And any neuroradiologist worth his salt will tell you this is most likely ANE. Once he says it's ANE and the clinical picture fits and the biochemistry fits as well. So if you do a CSF, you get only proteins increase, no cells. And if you do a liver function, you get high SGPT-OT. Treat this with tocilizumab as soon as possible. People still give methylprednisolone IVIG, which does very little. Tocilizumab is a cytokinopathy, and therefore you need to give tocilizumab. IL-6 is very high, and it's causing the damage. Because this is a very important, and people, pediatricians are the ones who see it. For some reason, it doesn't work very well after 72 hours.
Then NMDAR also is IVIG useful or steroids?
Yeah. In fact, the first line treatment of NMDAR is steroids or IVIG if it's a mild NMDAR. Mild in the sense sometimes NMDAR can be only a monosymptomatic thing. Usually the ones who come with encephalitis, the whole works, psychiatry, behavior, seizures, etc. We give both together. We give first steroids and followed up with IVIG as a first line treatment. If there is no improvement in 2 weeks, you give the second line treatment, rituximab or cyclophosphamide. You understand? And then there's third line also, but we won't go into that. So basically what I'm saying is you need to treat autoimmune encephalitis. And remember, it takes a long time to improve. Even if the patient is getting better, it'll take few months. ADEM, on the other hand, improves fast. So ADEM, it's a demyelinating disorder. It's not really typical encephalitis. Though it's part of the immune problem.
Start with methylprednisolone. Do we take?
Yes, 100, always. Start immediately. If you have MRI picture suggestive of ADEM, don't wait. And when you start the methylprednisolone, this is the first line treatment. If the child usually improves within a week, and if he doesn't improve in a week, you can use the second line. You're still sure of the diagnosis. is the second line. Now, younger patients, people use IVIG because it's difficult to do plasma exchange. In older patients with more severe disease, you do plasma exchange rather than IVIG. So that is the thing you should do as soon as possible. And that usually within 2-3 weeks, they're doing very well. And by 1 month, like they're fully recovered. So that is the thing when you decide 7 days. The improvement starts within 3-4 days. In 7 days, his improvement is obviously seen. If not seen, you give the next treatment, and the maximum ADEM will go away in a month's time. Well, autoimmune encephalitis takes a much longer time. There's some questions on by Girish.
Yes.
Can you see that?
In NMDR encephalitis, to prevent relapses, do you target disappearance of antibodies by giving rituximab repeatedly?
No, well, not really, because the NMDR antibody may persist for a long time without any symptoms. So in the past, they used to use the antibody, but now for the last many years, people have stopped using the antibody as a guide to treatment. So how long do you treat? And that depends on the severity of the illness. So the illness is mild, 6 months is okay. If it is moderate, there are criteria for what is mild and what is moderate and all that. You can use for 1 year. And the severe ones, which sometimes take a year to improve, you give it for 2 years. And these are all arbitrary consensus figures. They don't have any evidence behind them. But generally, for example, if you have a patient of NMDR who's been comatose and having movement disorder for a few months, please don't stop within 6 months. Give it for 2 years. But if you have somebody who has monosymptomatic ataxia, chorea, thoda seizures ho gaya, behavior change ho gaya, you're given the first line, he's much better in a matter of 3 months, then fine. Give rituximab for 6 months to a year maximum. And keep the CD1920. That is what you use as your guide. You must keep it below 1%. So whenever every 3 months, so first when you give it, you do your CD1920 in a month or two. And you give it at least, I give 4 doses. Some people give 2 doses and then check. And after 3 months, if the CD1920 remains low, you just keep checking every 3 months. Once it goes down below above 1%, give 1 more booster dose. You understand, right? And keep that CD1920 down for at least a year average.
There are 2 more questions. So going back to headache. So assuming that it's not the bad headaches which you spoke about, then how do you treat it? And if it is a migraine, then how long do you give flunarizine?
Okay, so the first thing is headaches need not be treated always. So if you have occasional headaches, acute treatment is enough. If you have migraine, for example, many of us have migraine. You have a bad headache, what do? You put the lights off, you go to sleep in a dark room and sleep. And take a crocin or you take a ibuprofen or whatever it is. If it's recurrent, if it is more than, say, 4 times a month and disturbing your, at least 4 times a month and disturbing your routine activity, then you may go to chronic medication. But before that, how many of us give lifestyle precautions? The lifestyle precautions in migraine is extremely important in treatment. So in our situation, what we do is in our clinic, first you tell kabhi sota hai. Everybody is sleeping, especially in Ulhasnagar for some reason, everybody sleeps at 1 o'clock, including the kids. Then you get headache. How can you not get a headache? So first of all, the sleep. You require a good amount of sleep. And it should be nighttime sleep and not afternoon sleep. Because the nighttime sleep is restful. You go through the REM stages, etc., which prevents all these headaches from occurring. Second is hydration. I've told many of my friends and my family also that you must drink enough water, but they don't. And therefore they get headaches. Third is early morning food, breakfast must be given. Don't fast for too long. Fourth is triggers like sunlight, etc., very common. So wearing sunglasses, etc. And fifth is occasionally foods. The 3 C's which I use, chocolates, cheese, and Chinese, with MSG, that you can. But first, you must try just acute treatment with these lifestyle precautions. and keep a headache diary, and still the headaches are continuing, then you start thinking about flunarizine, propranolol, topiramate, there are many drugs you can use. And that depends, flunarizine, one of the major problems is the weight gain. Huh? Tremendous weight gain you can get. You can be careful, but it's a very good drug. You can give that, you can give propranolol if there's no asthma. You can give topiramate, especially if somebody who's obese. So all these things, but usually you give for 3 months and then slowly try and taper.
Okay. I think this will be the last question for the session. In cyclical vomiting syndrome, what preventive therapy you find most effective? Any use of mitochondrial cocktail?
Yes, I use carnitine because I don't know how it really works. But besides using anti-migraine drugs, if this thing is persistent, and sometimes you get it's triggered by things like menses also, especially in adolescent girls. I've used carnitine, coenzyme Q, and I think these are the two ones I mainly use, along with anti-migraine drugs. Lifestyle precautions, and we hope for the best. But sometimes it's really difficult to stop. But you must, I think, go ahead with the coenzyme Q and carnitine at least.
And so migraine with
And riboflavin. So I give there's one drug which is I give brentamine. It's a combination of riboflavin and magnesium. So this also can help.
okay. And so migraine with obesity, what is the choice of drug? Can we use topiramate?
He's given the answer. Topiramate. Remember, topiramate has to be given slowly, and it takes time for these drugs to work. So don't expect miracles within a week or so. Usually, anti-migraine chronic therapy is over a period of weeks. So you start off, say, mostly the time you're using migraine is adolescents, bigger children, adolescents. So you start off with, say, a big girl or big boy, 25 milligrams at night. You wait for at least a week or 2 weeks before increasing it, and go to 25 milligrams twice a day. And then you wait for another 2-3 weeks. And if you're not getting better, go to 50-50. Usually, migraine doses of topiramate are lower than epilepsy. So 50-50 is usually enough. And remember one thing, in older patients, please do eye pressures before you start this drug. On day 0, eye pressures, intraocular pressures, rarely can go up. And people have got sued because of this, especially in adolescents. In older patients, like in my age patients, you must check the pressure. But even in adolescents, where it is rare, it is better to check the pressure. Day 0, day 7, day 15. If the topiramate, if the day 15 passes, then there's no issue. They usually don't get any problem with the eyes. But give it for at least 3 to 4 months, and then slowly taper it off if the headaches are much better.
Should we take one last question?
No, you can take. I don't mind. I'm fine.
Why is drug-free weekend recommended for flunarizine treatment?
Basically, I'm thinking why is it recommended? It's not routinely done by everybody. But basically, it's migraine. If you give them in a drug holidays, the weekends, and all that, the side effects, especially obesity and all that, become less. That's what I believe. But remember one thing: that migraine often comes after a heavy week. So very often it comes during the weekend. You must have noticed, I don't know how many of you are migrainians, but when you're working hard and all that, the headache doesn't come on. When you relax, it comes on in a big way and screws up your entire weekend. So that's one of the reasons why I don't use it. If I'm going to use it, I use it continuously for 3 months. Somebody asked me about chances of fundus normal in ICSOL. In children, remember, papilledema is very often, and more the acute, it depends on the history chronicity. See, the history is more chronic, your papilledema has time to develop. The history is very acute, unusual. So ICSO is like, for example, a subdural hematoma or something coming up, or something of that sort. You may not see anything in the fundus. Second thing, low dose aspirin. Standard of care. It's not standard of care, but it's what many people are using, including us. We did a paper many years ago in 9-10 patients of aspirin, and we found that even in the younger patients who are having severe seizures and all that with Sturge-Weber syndrome, giving the aspirin seemed to just quieten the disease a lot. We also showed that the MRI changes, became less with aspirin. So I use it routinely, yes.
And any experience with race syndrome secondary to low dose aspirin?
The chances of Reye's syndrome generally has gone down everywhere in the world, primarily because aspirin use has gone down. Aspirin was being used as an analgesic. That has gone down. So I don't remember any patient of mine with aspirin causing Reye's syndrome. But some people believe that if you have influenza, some sort of infection, then maybe it's better to stop the low dose aspirin at that time. Maybe it is. I don't know.
Anyone has any other questions for sir? You all can unmute and ask as well.
Okay, somebody is asking about tics.
11-year-old girl with ocular tics, blinking of eyes. Is any treatment required?
No. Short answer is no. Tics are not harmful. Tics mostly are noticed only by over-anxious parents. Tics are usually transient. So unless they're embarrassing the kid, or unless she's being teased, or unless there's other many tics coming, or if there are a lot of vocal tics, because vocal tics are extremely disturbing to other people, and it's sort of people look at you when you do that. In those situations, you can give pharmacotherapy. Pharmacotherapy usually start with arcomin. It's clonidine. It's a safe, generally not much of a problem, fairly effective. Don't start with haloperidol. Definitely not, because there are lots of other drugs. Then there are other drugs which I prefer: risperidone, tetrabenazine, aripiprazole. But these, once you have tics which you want to give treatment to, remember, you try to give it for a few months and then try to taper it off, because very often the tics don't come back for a long time. But once you got Tourette syndrome, it's better to refer, because then there are lots of things which come up with that.
Okay. Any more questions?
I think everybody's tired.
Yeah. No, I think we had a very good, fantastic 1 hour of learning, and I think that's the point at which everyone attention span starts waning. Girish is asking, what drug do you use for dystonic CP?
Well, I generally start, my preference is gabapentin, which I'm sure many of you must have noticed, whoever refers to me, that I use gabapentin very freely. It's a very safe drug. It acts on the sensory part of the dystonia more than the motor part. And it basically, remember, dystonia is something which is precipitated by stimuli, by action, by stimuli. So any somatosensory, any pain, all those things which are sort of worsens dystonia. So gabapentin is a very useful drug. And even in young children, if you have patients who have, say, HIE at birth or something, you watch them closely and they're developing some dystonic postures. I even start at that time, even the earliest signs. The reason being that if you're not sure, don't start. But because it prevents the development of dystonic postures. The other drugs, of course, we use are trihexyphenidyl, but that has to be used in much higher doses than the routine. Then you can use clonazepam, you can use tetrabenazine, you can use lots of other drugs. But basically, baclofen. But the most one I use in my practice is gabapentin followed by trihexyphenidyl, which is Pacitane or Bexol. These two other drugs are used. And of course, look for why the dystonia has worsened. So hunger, pain. I mean, I remember one patient of dystonic CP. I was following him for many years, and I lost follow-up because he became an adult. And I was called when he was 25, and he was severe dystonia. He was a fully normal kid otherwise. He could communicate with his eyes and be very expressive and all that. And he was gone to dystonic crisis. I went to see him at one hospital. And what did he have? He had hip dislocation of the hip. And he couldn't express that. A severe pain. He was in severe. Then X-ray, and they found that he had dislocation of the hip. It was fixed and he was fine. Back to normal, back to where he was. So remember, stimuli, constipation. That's why I don't like, sometimes when you give high doses of trihexyphenidyl like Pacitane and all that, you get constipation, which actually triggers the dystonia even more. So you have to be very careful. That's why if you have a very bad dystonic, you use gabapentin initially. Once it becomes complicated, it becomes difficult. Okay. Okay.
Thank you, sir. I think it was a fantastic learning for the last 1 hour, 1 hour, 15 minutes. I think, Amruta, you can wind up.
Sure, sir. Thank you so much, sir. That was truly a brainstorming session. Yeah, so we'll end this episode 3 today. Before wrapping up, I would just like to remind our members, those who have not voted already in the CIP elections, kindly vote. And the e-voting will end on 5th November at 5 p.m. So please vote, those who have not done already. And tomorrow we'll have the last and the final episode of this Webflix series, which is antibiotics in office practice. And for that, we have Dr. Tanu Singhal madam as our third umpire. So see you all tomorrow at 9:30 p.m.
Okay, thank you very much, everybody.
Thank you, sir.
Thank
Thank you so much,
you,
sir.
sir.
Thank
Thank
you,
you.
sir.
Good night. Good night.
Good night, sir. Good night.